This is Pam James from the Coordinating Center, and I just wanted to introduce Kelly Parent. She's from our Department of Patient and Family Centered Care. She has done a great deal of training with the advisors who are working with our I-MPACT project here at University of Michigan, not just our patient caregiver advisors for the team locally here, but we also work with a large group who's advising the Coordinating Center in general. She's been kind enough to go through sort of the information that she shares with new advisors and to help give the people at the sites a little bit of information and training and how to work best with their advisors and how to prepare them for their participation in I-MPACT. Kelly, are you ready to go?
I sure am.
Okay, I will let you have it.
Okay. Thank you very much, Pam and Beth. I know you're out there as well. We've done a little work prepping for this. I'm really happy to be here. This is a new area that patient and family-centered care is becoming more formally involved. And when I say formally, I mean that there have been pockets here and there where advisors have been involved in quality projects for a number of years, but it's never been to the extent where a Blue Cross Blue Shield or some other group of the like has actually stepped forward saying we really would like to do more and make sure that we have engagement of our patients and families on all aspects of quality improvement projects. So today I'm going to be going through this PowerPoint. And the PowerPoint, actually, I think this is really the very first time I've given this PowerPoint to a mixed group of some staff members that are involved with quality projects and some patient and family advisors together. I've spoken with each group separately, so today is that attempt to pull it all together so that everyone is hearing kind of what each other is hearing, so that we all are coming at this from a true partnership standpoint. So my background is I started out as a family advisor in 2006 at Mott Children's Hospital. My daughter was diagnosed with cancer when she was 9 and treated through 10, and she is 21 now, so I'm knocking on wood here and ask all of you to do the same. But it really is life-changing, and it really put me in this place of figuring out what can I do that will make some kind of sense out of what has happened, in our family. And so that sent me on this path of first volunteering and then being hired as the coordinator of the Patient and Family-Centered Care Program at Mott, and having that grow into something that has become pretty involved, pretty big, and you'll hear a little bit more about that as I move through this. So today we're going to stick specifically talking about quality projects. I probably, as I usually do, will go off on a few little tangents here or there, but hopefully they will be very pertinent tangents, sharing my experiences as an advisor as well as a program manager. So you can see on this slide, for those of you that are not on the web, we do have this, the PowerPoint being shown through computers, but if you're only on the phone and you have the PowerPoint separately, I'm on the objectives of training session, so that's the second slide. And from this point forward, hopefully you'll be able to just, follow along pretty easily. So the objectives are a bit of mirror images. So for the principal investigators or faculty or staff members, we are looking to do a little bit of definition of what patient and family-centered care is. We're looking to help you identify opportunities where it makes sense, where it's rewarding, where it's effective to engage patient and family voice in quality partnerships. Looking at how to best engage them, as well as sometimes community becomes an important area of engaging community in quality projects. And then also, I can easily share what the process is for accessing our patient and family advisors at the University of Michigan, but I'm also going to plant a few seeds. If you're from a different institution, you need to figure out how you go about accessing these advisors, so we'll talk about that a bit as well. For the patient and family advisors, a lot of them are the same thing. We want you to understand what your role is and what your role is not. And we want to make sure that you have the confidence and skills and knowledge, understanding what it is that's expected of you. And the most important thing to recognize at the front is that for those advisors out there, you are not expected to become a professional. Your voice, because then you're not giving the patient and family advisor voice. We want you to be able to share your experiences and share your wisdom that you've gained because of the experiences that you've experienced in healthcare systems. So moving on to the next slide, I want to spend a very brief period of time talking about what patient and family-centered care is, and then a little bit more talking about what the patient and family-centered care program is. So I really wish that I was seeing all of you, because I would ask you all to raise your hands to find out who out there has actually either already experienced involving patients and families in work that they're doing at their healthcare institution, or who out there have already been patients and families that have engaged in different types of venues. Over a number of years, we have been very involved with trying to improve clinical care processes, which is a really nice lead into what we're talking about today, which is quality and even safety. We have also been involved a lot with educating through story. I can't tell you how many times I have been asked to share my experiences or to bring other patients and families, because it's not just about my experience. We want to make sure that we are bringing all different types of diversity to the table so that people can hear and understand what these experiences are like for people living in a variety of different unique cultures and having unique experiences. And then we are also absolutely are getting involved in the research world, because more and more we're seeing that people that are providing funding for research are asking if the researchers have actually engaged the voice of the patient and the family. And that's where I think quality improvement initiatives are also going to land. I think they're going to take their cue from some of these research organizations that have required that. So when we talk about what patient and family-centered care is, I can talk forever on what it is, and I could also talk forever on what it's not, but I want to keep it very, very simple today and really just stick with understanding that it really comes down to the word with. Patient and family-centered is really talking about what it is that we're doing with our patients and families at the point of care. How much are we communicating with them, not at them? How much are we making decisions with them, not for them? But it also is about this with whenever we are looking at what types of projects do we need to work on next. Only people, staff and faculty clearly see from their perspective where gaps are, but patients and families have that different perspective. And so it's really important for them to sit at the table, to sit in these classrooms, to sit in the boardrooms, to share what are their experiences, what matters to them. So the word advisors, I feel it's really important, since I think we're coming from all different areas, is to speak for a quick second about what advisors are. So throughout the rest of this conversation that we have today, or somewhat two-way conversation. We'll try to make this a little bit two-way. Advisors are people that I'm referring to who have had experiences in the healthcare system and are wanting and willing to step forward and share their wisdom and advice based upon those experiences. And the word partner should be highlighted here, because it's about creating a partnership with our staff and faculty. It's not about coming in and advocating and demanding, this is what I want, this is what I expect. It's about coming in and saying, this is what went well, this is what didn't go so well. I'd love to sit here and brainstorm together so that we can figure out how to fix what isn't working so well. So our advisor forums are not complaint sessions, they're not support groups, and they should not be therapy. However, it is okay to share negative experiences, couching them in positive, language. It is absolutely okay when you leave a meeting like this saying, wow, that was awesome. That really helps find that silver lining out of an experience that you had that maybe was a little darker than a silver cloud. It is that silver lining to that darker cloud. So in obtaining the voice, there's so many different ways of obtaining the voice of our patients, our families, and our community. And I separate community because there are a lot of people who have not been involved in the healthcare system that someday will, whether it is through their, God bless them, 50-year-old time for your colonoscopy screening, for your mammogram, for whatever, screening that it might be for, in the community where you are not ill, but it's just you're going in for screening through people that have had, lengthy experiences or even short-term experiences in healthcare institutions. So some of the best ways for engaging the patient, family, and community voice are pulling together focus groups where we say we want to talk with, 8 or 10 people that have had experience with I-MPACT with transitions after, whatever the transition is that you're working on. And we can pull those folks together. We can also do this virtually, like we're doing today. We can have presentations. We can have different social media networks where you can sign up and you can have an ongoing conversation where you are throwing out a question, and a lot of people are on this discussion board giving their answers, and someone, it's a continuous thread of virtual participation. You can also pull together a work group that has the right stakeholders from the hospital or the healthcare setting, as well as some patients and families, to be part of a work group that is time limited. When the work is done, we move on. But there are also opportunities to take this big and to go into a town hall and to say, I would love to go into, all right, there's a researcher in Illinois who's looking at mental health, doing some mental health research or quality projects. Sometimes those words are used interchangeably, but there are some differences. And so what they will do is they said, we want to understand what are the stigmas associated with being diagnosed with a mental health disease when you're in the Hispanic or in the African American communities, because they have seen some gaps with getting care and with stigma. So they said, let's go into churches, let's go into community centers, and let's talk to real people living in real communities about this very real topic. And so that's what is meant by a town hall, is going out and doing that. And then finally, there are some opportunities for the folks working in the QI projects to be able to come to an advisory council that a hospital has set up, where there are people that have stepped forward, meet on a monthly basis, and you can go in and pick their brains. So as I go through this talk, you'll see at what point each of these different venues might work the best in which stage of the quality project that you're working on. So as I go through these slides, some of these first slides are a little more weighted for the staff and faculty that's sitting in the audience, but again, it's important for everyone to hear these things. And then the last slides are weighted more heavily for the patient and family advisors. So that doesn't mean that half of you can check out now and the other half check out later. I'd love for you all to be able to listen to all pieces of this. And the other piece that I would mention is, once we have some of these results and we've learned a bit about what you're going to learn in this I-MPACT project, the question becomes, how do we get this out to our primary care providers, to our ambulatory care providers, to our attendings in hospitals, to whoever it is that needs these wonderful findings that you are going to learn. And it is important also to reach out to these groups and maybe even have some virtual participation or focus group participation with them, finding out how we can best feed them the information that we have learned through this project. So e-advisors, I wanted to spend a moment. The University of Michigan has an e-advisor program where we have over 800 patient and family members that are out there in cyberland that know that they will be getting emails that have short surveys where we might ask them questions about a certain topic. We tell them, you don't have to answer any survey ever. You only answer the ones that you're interested in, the ones where you have time, because we never want there to be pressure, because there are times where we send several surveys out a week. But again, if it's something that you are not interested in or you don't have the time, we just say toss it in the trash. But if we get even a 10% response rate, we have 80 responses because we have 800 people on this list. Yes, we're a mature program. No, I don't expect most hospitals out there to have 800. But if you had 50 and you got, and you really sought to get a 20% response, even 10 responses can be helpful to give you an idea of what some of the thoughts are that are out there. So we use this list to be able to send surveys out anonymously, so that people can answer this, and we never know who said what, and we're not concerned about that, because what we're mostly concerned about is the opinions of a wide variety of people that are out there. So this program works wonderfully for those people that are not able to come to our meeting, those people that maybe are still too sad or still might harbor some frustrations about an experience that they may have. But when you're online, you can share these experiences and get the feedback from everyone who have had a multitude of experiences. So when we're pulling in people to sit on I-MPACT and to sit on other quality improvement groups, such as the one that you have, it's really important that you look at the demographics of your healthcare institution and that you make sure you do the best job that you can. And I say that because at Michigan, we don't have the picture perfect representation of advisors. We keep working on it, and it's a constant journey to be able to make sure we're getting that voice of everyone that it is that we serve, so that we understand people from all different walks of life and all different life experiences. And when we do that, so the e-advisors, again, we're not concerned about people that might still harbor some strong emotions about an experience because they are responding in anonymous surveys. But when it comes to people being able to sit on councils, to sit on focus groups, to be on project task forces, we absolutely want to make the commitment, as our volunteer program does, that we are going to look for people that know how to be constructive, that know that the timing is right and they can participate, they understand what the expectations are, and that they do have a passion in the topic. We do not look for people that have professional expertise in an area. I do not have expertise at all in research or in quality projects. I feel that over the years, my expertise has really come with understanding how and why to engage the patient, family, and community voice. And whenever we speak to staff and faculty, it's helping you understand how to best ask the questions so that the patients and families and communities will be able to answer the questions to get to the answers that you're looking for as far as where are our issues, how should we move forward, how should we reword this, et cetera. So by stacking your program with advisors that are doctors and nurses and quality assurance people and public health folks, that's not what we're looking for, and that absolutely is not what we're recommending. We recommend having a variety of people on these different groups. So the advisor training today, the first green little section on this slide that reads General Advisor is the advisor training that should have already happened before our conversation today. Now, I understand that with I-MPACT, time is of the essence. We might need to do things in a little bit backwards of an order, but it is really important for your healthcare institution to be involved in helping to onboard these advisors so that they understand and they sign HIPAA agreements and they sign code of conduct agreements, and that someone has the ability to talk to them about what are the guidelines, what are the boundaries for volunteers. I'm talking about maybe what are some of the difficult issues that come up. At the University of Michigan, we actually do training that has this general information, but we also talk about what patient and family-centered care is. We talk about what this might involve. We talk about the challenges of being a patient one day and sitting on a council or committee with your provider, the next day, and maybe some of the awkwardness or challenges that might come up as a result of that. So I am going to, at the end, you'll see that I have my contact information surrounding these volunteer onboarding questions. If your institution does not have an onboarding process for patient and family advisors coming to join councils or committees, I am happy to talk with you and see how we might be able to help you find a solution to make sure that these HIPAA and code of conduct pieces do get signed and background checks are done and all these different pieces that we have found to be important parts of the process. Today, with this, the bluish purplish section that reads quality specific, this is what we're going to go into at the end of today's webinar. The last half hour or so will be really dedicated to helping our patient and family advisors get a very basic foundational understanding of quality improvement terms and methods and data and timelines and what this potentially means, not to become an expert, but not to absolutely hear these words for the first time when you're sitting on your project. And this lighter purple, this more magenta color, which is project specific, we are really very strongly recommending that the I-MPACT project and every other Blue Cross project that will engage advisors will absolutely come up with a with a sheet that gives an overview of what this project is, provides a list of terms and acronyms, talks about what outcomes and milestones are that you're looking for, and talks about what the expectations are for that advisor. Are these things where they're going to be required to come in for, a monthly meeting, an every other month meeting? Are there ways that we might be able to work in to do some teleconferences or webinars? So thinking through these things so that people have a real clear understanding of what it is that's involved. And then, of course, introducing the team. That's a very important piece to it. So I'm going to stop for a moment here and find out whether there are any questions. And please, I'm not sure, Pam, whether you prefer people to chat them in typing or whether you would like people to unmute if they have a question.
I think we can have people unmute unless for some reason we start to have like 5 or 6 people talking all at once, then we might go to chat. But I think we can unmute for now.
Okay. So if there's a question or two about this advisor training piece, let's address those. If not, I will move on. Okay, so I'll assume that if you do have a question, you can hold it, and there'll be more opportunities to speak to those questions a little later. So the types of storytelling, in the training that we do, we also talk with our advisors about the different ways to share a story. And whenever you are teaching in front of a classroom, and I will say, you know what, you have 15 minutes to share, giving you some guidelines, some information about your story and how this pertains to the topic of what you're trying to get across. That is called a classroom story, and we jokingly refer to it as the narcissistic story because it is all about you. That's the whole intent of you going to that classroom, is to share your stories and to give and help with lessons learned. When you're sitting on a committee like this, your story needs to be really narrowed down to what we're calling the elevator version, where you're giving when you're asked to introduce yourself in the beginning of the meeting, it's a very quick, 30-second background. My name is Kelly. I have 2 kids. My son was born with a club foot. He had 4 surgeries before he was a year old, and he is 19 and, playing every sport imaginable. My daughter was 9 when she was diagnosed with a form of brain cancer. She went through radiation, chemo, and had surgery, and she is now 21, and she's a junior in college. So that's my elevator version, because what I've just shared with you is the basics to what my healthcare experiences have been as the mother of 2 kids, and sampling of what experiences they've had, and then more importantly for my daughter, it's letting you understand where she is today so that people know the outcome of that situation. So that's kind of an example of what that committee story looks like. Now, later on in that meeting, I am going to be pulling on an experience that I had to illustrate a point, not just to share my story just for the simple sake of sharing my story, but it's to illustrate that point. And then the peer support story is a completely different type of story, and that is where we are making sure that people understand how to share enough about themselves to create relationships, but not to overdo it with sharing, with too much information. So moving on to advisor engagement and quality improvement projects. So when you look at this picture, I would love to see, again, with the raise of hands, but I can't. How many of you see a vase in this photo? And I'm guessing that some of you do see a vase, but I'm guessing that others see the profiles of 2 people looking at each other. And sometimes it might take a second to focus in and see it a little bit differently, but that's what we're talking about. We are talking about making sure that we're getting enough voices at the table so that we have the opportunity for people to share how they're viewing the same experience, but differently. So these patient and family advisors absolutely contribute to quality projects. And most importantly, they're going to be the ones that kind of ground us in that real-world experience. They ground us, reminding us that healthcare is only one part of their life and that there are other things that are also important in their life, hence the word quality, and that they're going to absolutely help us be able to communicate things in words that the general public are going to understand. And my favorite is the 2 words together is what matters. When you ask someone the question, what's the matter? that immediately puts up a negative tone where clearly someone thinks that something's wrong, so they're asking you what's the matter. But if you get rid of the word the and you ask someone simply what matters, they are going to share with you what makes a difference. And so when I think about my daughter, her attending school as much as absolutely possible so that she can be as normal as absolutely possible and not sitting out of gym and not being the different one in the class was what mattered to her. So we really worked with her doctors looking at how we can send her to school when her blood counts got really low. We worked with the school on how they can make sure that they were wiping desks down. We actually also worked with the parents by sending updates with emails out to the parents, just letting them know, kind of every once in a while how things were going, and just asking them very respectfully if, their children had, some communicable disease, to not send them to school, which they shouldn't be anyway. And we got no backlash whatsoever because we really recognized that in order to provide her with high quality care, we need to also treat her as the little girl that she was as well. And everyone was willing to do their part, but it took communicating with a big group of us to do that. So the word the PFE stands for Patient Family Engagement, and HRO stands for High Reliability Organization. So let me first define High Reliability Organization. And that basically is an organization that is at risk for making mistakes, but does what they can to prevent these mistakes from happening. And so when you think about healthcare, there's a ton of places where errors can happen in healthcare. And we all know that. And humans are humans, and complex processes are complex processes. But institutions that really work to develop processes and to develop communication and to develop a culture where people are willing to step back and listen to each other and really be a team is what we're shooting for. And institutions that recognize that patient and family is a part of that team is what I'm talking about here. That patient and family absolutely is part of the team at the point of care and at the institutional level. So I'm not going to read through these. You can read through these on your own, but you need to ask yourselves about your institutions. And this might also help with thinking about your impact project and how you'll move things forward as far as these creating self-management models and creating safe models and creating coordinated care models so that people transition from one type of care or service to the next with minimal risk for adverse events occurring as a result. So when we engage our patients and families in quality improvement projects, there are a bunch of ways that we can do it, but I've tried to classify them into these 4 ways. The first one is the patients and families can provide feedback about an idea that you have, discuss issues about the idea that you're bringing forward, and help resolve questions and concerns about that idea. But they can also come up with ideas on their own. And if you ask questions in the right way, they might, again, see those profiles of the 2 faces looking at each other instead of seeing the vase and be able to come up with, share with you something else that you hadn't even thought of that might be a direction that you'll want to go with your QI project. So we ask that you absolutely don't wait to engage patients and families. You bring them in at the beginning. They serve as a language lens, so they can review materials, they can review scripts, they can help you decide what is the best type of information, how it can be given to our communities and our patients and families that might be newly entering the diabetes world or newly entering the heart disease world. They also are very, very helpful in helping to communicate what it is that you're learning or what you want to learn to their patient organizations and groups. I know I belong to a pediatric brain tumor online support group, which it's sometimes a little less about support and more about providing information, because we all know that the internet is where a lot of us go for information. Like it or not, it's happening. So if we can help get good information about good work that we're doing out to the public through some of these groups, a lot of your advisors can help disseminate this information to their patient like me organizations. And they also, as I said before, they can help generate new ideas for these projects. So I said this in the very beginning, and I want to share this again because it is extremely, extremely important that the primary role of advisors in community are to attend the meetings, webinars, town halls, teleconferences, however, whatever it is that's set up, and to participate. And participation means sharing perspectives and asking questions. And those are the primary things that we want to do. It's up to the staff and faculty to make sure that you're providing opportunities for people to share things in ways and asking questions in ways that they're absolutely going to be getting at the information that you want. I can clearly say that if you came to me and you said, can you help me define what the PDSA cycle is for the I-MPACT project? I would sit there and look at you with my mouth hanging open and say, I have no idea what you're talking about. But if you asked me questions that are specific to the plan part or the do part of the process, then I can answer those questions and you'll get the answers that you need simply by asking me the question in a way that I understand, as opposed to in a way that stops in my tracks with me thinking I have no idea what it is that they're talking about. So this brings me to the engagement in the stages of QI projects. This was an adaptation for work that I've been doing with research, people doing research, but I do think that there's enough parallels that this works in the QI world as well. And so it's back to those places. It's putting together how advisors can be engaged and for what reasons are the best way, should they be engaged. So when you combine those two, that's when you get this colorful little rainbow graph from purple down through green. So the pinkish purplish is looking at the first two are identifying and prioritizing issues and generating your question as to what it is that you want to look into. And this is really a wonderful place where you need the voices of many people as far as professionals, and many people as far as staff, as far as patients, families, and communities. So this is where going to those town halls, getting together a focus group, visiting a hospital's advisory council, going online and having a virtual discussion of some sort. These are going to bring in a lot of voices with a lot of different perspectives so that you can hear what is going on out there and you can start working to prioritize these issues and then generate, where you want to go with your project. So you can clearly think, about, again, wishing we were in person. It's beginning, breaking off into a work group at this point and talking about with I-MPACT, what are some ways that you can ask questions so that you can help people identify and prioritize the issues that they come up with surrounding transitions. So let me share a little bit of an example from this. So Mott started their advisory council at the Children's Hospital in 2008. And one of the first topics that our advisors wanted to solve, so our advisory council consists of 2/3 parents/patients and 1/3 staff/faculty. And they said, we want to fix the discharge process. And these were the early days for myself, and I really was learning just as much as everyone else on the committee, with this advisory council existing for the first time. And I know the words for PFAC stand for Patient Family Advisory Council, but it didn't click in with me for a couple of months while this group sputtered in circles talking about how they want to solve the discharge process. And suddenly I realized that this group of patients and families and a small number of staff and faculty cannot solve this problem. We have a lot of people being paid a lot of money with a lot of professional degrees that struggle with trying to fix this problem. So what I realized is I said, let's talk about what advisory means. And so what we realized is that we are there to advise people on where the problems are. So what they did next was that they came up with their 7 issues surrounding the discharge process. What are the 7 areas that are the most frustrating or filled with the most chance for issues whenever they have, in this situation, it was pediatrics, their child was admitted to the hospital? And so from those 7 topics, I started inviting the right stakeholders at the hospital to come to the advisory council meeting and to ask them to explain a little further on what the issues are surrounding home care or what the issues are surrounding getting too much paperwork on the last day, or what are the issues surrounding getting outpatient medications, whenever you're discharged, et cetera, et cetera. And that really was extremely eye-opening. One of the greatest lessons that I learned was that the advisors are there to advise, and they're there to help you through the process. So these first two areas is about getting the voice to advise you. The next two, which are more the bluish, the project design, the project implementation, you don't want to involve a huge number of voices for this, because we all know that we'll never get anything done if there are too many voices. So you take a couple of advisors and they join your project like you're doing now. So that is exactly where you are with I-MPACT, is let's take a couple of advisors and they're working specifically in this area because this is where their interest and their passion is. And they can help with developing, the methods or the design of it. They can help with implementing it, with recruiting people, with enrolling, with collecting data, whatever it is. Again, I'm not a QI person. I'm not a researcher either, but those two kind of meld together. And the third section, whenever we're talking about, we now have this data that we've collected, and it's time to interpret what this means and come to some conclusions, and then to disseminate these findings. So this green section is a place where, again, you might want to have some fresh eyes, and you might want to get more advisors involved. So this might be the place where you go back and you say, I'd like to pull together another focus group. I'd like to go to an advisory council again. I'd like to go into a town hall again to get a larger number of voices, so that we can share with them the percentage, all the results, the numbers, and actually ask them why they think the numbers turned out the way they did. In their interpretation, they might be able to come up with a different focus again on something, their analysis as to why they think the information has resulted the way it has, and to come up with a process improvement and moving forward. So it really all comes down to stories. And so that's what all these beautiful faces are about. These are all faces from stories online where processes fell apart and harm happened to every one of these people because our processes, not ours at the University of Michigan, but ours collectively as a healthcare system, just did not work. And each one of these situations, each one of these, either the person themselves or their parents step forward saying, something is not right. You need to listen to what I have to say. We need to fix this. In each of these situations, it wasn't until it was too late and something bad happened before people took, notice. So I firmly believe bringing the advisors in the beginning, hearing stories, being willing and being brave enough to listen to stories, even when it might be stories that make us feel really sad or really bad, is really important, because it is going to make a difference in the end. So guided storytelling methodology, this is something that I'm working on in the research world, and I think that it can translate into quality world as well. It's what kinds of questions, how do we ask questions in the right way so that people can actually give you answers that make a difference? And so these are some very, very quick examples of whenever you're talking to an advisory council or you're talking to your advisor that's on your project, work, and you can ask them about what the different choices are and how that will affect their life. Ask them defining what quality actually means in a certain situation. Ask them what it means to their family. Ask them how they best like to receive information. Ask them what matters. So it's how we ask the questions that's really going to make a difference on how successful we will be in the end. So this slide is really busy, and it's really busy on purpose. And this is an example. It's a transition example. So this was published. It's been published everywhere. I found it in the Huffington Post a couple of years ago. And this is called Gabe's Care Map. And Gabe is a young boy who has a whole lot of health issues. And Gabe is in a family. So Gabe is in the center, and his family surrounds him. Gabe's mom was asked to write down what it takes to provide good care for her son, to take care of Gabe. And she could not do it. She could not. She was having a hard time finding words to actually write this in narrative form. So she drew this graphic with each color representing a different part of Gabe's life, from legal and financial to recreation and community to information, advocacy, and leadership to school to developmental assessments to his health care to support. And each of those areas gets broken down into smaller and smaller and smaller groups. And One of my favorites is taking a look at school, and you look at one of the people that she has on the list as being important in Gabe's life is the bus driver. And if any of you out there have a child with special needs, you'll know exactly what she's talking about. But for someone that doesn't have a child with special needs, it never would dawn on you how that person needs to be part of the process and needs to be in the fold. So when you're talking about transitions, whether for whatever the situation is, this is how you can start getting at where are the breakdowns in the systems. And if you're wondering why they're not following or understanding or heeding what it is that you said to them, you're one circle on this map of many, many circles. So that's the type of thing that by asking and hearing stories, you can really understand things a little bit better. Finally, as far as advisor engagement in QI projects, I want to make sure that you absolutely understand that advisors can also really play a huge role in helping you to allocate funding for projects that you might want to work on. I have shared my story multiple times, depending upon the venue, and these personal stories I'll never forget sharing at the Pediatric Brain Tumor Foundation's fundraiser, and this was a motorcycle ride. And as I shared my story about my daughter, and my daughter was there with me at the time, all of these men and women both started opening up their wallets and started handing money, not for us personally, but for research. And they said, we want to make this better. We don't want this to happen. And that's what a story can do. So the story, as far as getting, having different organizations fund work that you're doing, wonderful. Advisors can also be involved, or in family-centered care programs can also be involved in writing letters of support whenever you are looking for funding, saying that this is how our volunteer program can help you. We can pull together focus groups. We can survey people online. We can give you a couple of advisors to sit on your council or committee. And our advisors can also look at your proposal that you've written and then give you feedback saying, that's great, but did you think about adding X, Y, or Z? And there might be something else that would come up that, again, with that new set of eyes can make a big difference. So I think this is my last slide in this section. I might be wrong, though. And this slide really I like as a summary slide, because after all is said and done, it is really important to remember that we are talking about a partnership. We're not talking about a power shift. We are talking about faculty and staff working in partnership with our advisors so that we can have this wonderful clinical curiosity and professional expertise in this real world relevant experience that come together, that create processes that are going to make life better for people that are following in my footsteps, people that are following into the pediatric cancer world behind me. So stop here again, just to give you an opportunity to ask any questions that you might have. You can unmute if you would like. I hope people are still out there and you haven't fallen asleep. All right, so we'll keep moving on. Oh, someone there? Okay. Okay, so we'll keep moving on. So this next section is talking about just a little bit of preparation whenever you are actually working with on QI teams and you're working with it, on the other side working with advisors. So the volunteer program, and again, I'm happy to help if your institution doesn't have a patient family-centered care group, staff member. I'm happy to help you figure out, what your next steps would be. It's really important that we make sure that you're understanding who it is that we are suggesting that becomes an advisor on your project council. So we have bio sketches of our advisors that we will share and say, these are the experiences they've had, and we can make sure that it's a good fit. And not because it's not a personal thing, it's really an experience thing. And so you're looking for certain people with certain experiences. We need to make sure that that fits. And likewise, we need to make sure with the advisor that they understand what they're getting into to make sure that it's a fit on both sides. We need to also meet with the whole quality team and talk with them about what it means to have an advisor join them if they have already been meeting before the advisor joins them. If everyone's starting together, that's great, but if they're not, it's understanding and answering those questions of, yes, people have signed HIPAA, yes, they have been talked, we've met people and we understand that they're ready for this. They want to do this. They're in a good place to do this. They're just as excited as you are to do this. And then if there are any concerns that come up, this is an opportunity to address that. We also make sure we go over with the team what they need to do, how they can best welcome the advisor if the advisor is joining a team that has already been in place. And one of the best ways that I've found is sending a couple of things, giving the advisors a few months of meeting minutes so that they can read and get up to, a little bit up to speed before they come that first meeting, but also assign them a buddy from that quality improvement group so that they can go there together and sit there together, and that person isn't joining the group all by themselves and feeling out of water. And that buddy on the committee can make sure that they're good, that they can be that host, and to make sure that they are asking questions and they're understanding what's going on. And then the idea of running effective meetings. Absolutely. When we have our meetings with advisors, we sure, just like with any group, sometimes it's fun to do a little icebreaker up front and just have people go around just to say, hey, it's what's going, well, we wouldn't want to talk about the election, but if it's the Olympics, what is your favorite sport, or what country are you rooting for? Something like that, just to kind of break the ice and make people get a little bit, become more familiar, especially if they don't know others on the group. And also one of my other favorites on this list is having that open door policy, making sure that there's time before or after the meeting that if the advisor has questions or concerns, there can be that time, or they have your email address where they can contact you and ask those questions. Reminder emails absolutely work wonderfully. People's lives get out of control busy, and having that reminder of don't forget, or meeting in 2 or 3 days or whatever it is really, really helpful. And then, of course, creating community and nurturing trust. And this is one of the most important pieces. I've talked with a lot of different groups out there that have engaged advisors in a lot of different ways, and they said that the time that they spent in the beginning to establish the whole group as a community and build trust was really, really time well spent, because it really made for much smoother processes as they went along. I learned with our advisory council that there are different advisors that like to participate in different ways, and so thinking about that. So do your advisors, do some of them like to provide their feedback, advice on a council or committee and be done with that? Do others like to actually take a project, work on things in between meetings and bring it back and have something nicely organized to outline for you in between meetings? So find out what makes people tick. What are the things that people are best at? Some are the group speakers and some are the quiet workers, and making sure that there's opportunities. Everyone has a strength, and it's finding out what each person's strengths are and pointing them in that direction. And then, of course, that open door policy also helps to remove obstacles if any obstacles arise. Evaluating the partnership, these next 3 slides actually are going to give you a little bit of background. I'm not going to read them. You have copies of this. But we absolutely want to make sure that we are taking a look at what has worked and what hasn't worked as far as engagement and training, including today, as far as the project work itself, and did you get accomplished what you wanted to? So these mirror image questions, the staff and faculty can answer the questions from their perspectives, and the patients and families need to answer the questions from their perspectives. And then go into value and meaning questions, and then finally, new directions. What has been the result of this, and have new things come up as a result of this partnership, where you have work that's going to last for the next 10 years because so many wonderful ideas have been generated because of this partnership. The slide that is evaluating effectiveness of advisors is beginning to think about what are some of the actual measurements that you can take a look at that might be able to be traced back to the partnership and engagement, because once again, this is a way of being able to possibly get funding if we can show how that advisor voice can make a difference on a project. These are some of the different areas that you can actually measure these types of things. Also, other ways to continue the support is if meetings are not monthly, or even if they are monthly, Sometimes a month is a long time to go by, but certainly every other month or quarterly is a very long time to go by that I'm not going to remember much of anything that happened unless there's some type of thread of conversation that continues in between meetings. So if possible, for as many people, advisors as are willing, engage people with maybe a private Facebook page or a Yammer page where you are keeping conversation going in between, but not on a public page, but on a private page that is specific to your impact work. You can also have more scholarly networks where you might be able to say, we have this C-Tools site or we have this Google Docs site. We would like to share this document so that you can, give some feedback and we can keep the work going in between meetings. So thinking about this, and again, I'm just tossing this out today so that these are just some ideas to think about, but I am available to help you with developing these types of venues if you're interested. And then finally, with compensation, this I have to enter in a little bit carefully because different institutions have different sources of money, and different advisors step forward for different reasons. Most people step forward because they want to volunteer their time, but at some point, if we're asking a lot of someone to come in every 2 weeks for a year and to sit on a meeting for an hour or two and to do work in between meetings and to pay for gas each and every time and to miss dinner and all of these types of things, we need to begin to think about in writing in with our, funding applications, how we can help our advisors with maybe some of these out-of-pocket expenses, especially if, if things are a little difficult, if finances are a little difficult for some of our advisors, because we absolutely want to make sure that we're hearing from every segment of our society and not just people that have the means to be able to come in for a meeting and to afford to miss a half day of work to come into a meeting. So that's where this section ends as far as the next section is going to be more or less the Quality Improvement 101. So I really would like to stop here. We still have about 35 minutes to go through quality in the next section. But if there are questions, particularly from our staff and faculty that might be on the call, but also advisors surrounding next steps, your institution, some of the things that you've heard, I'd love to address these now before we move into the next part of talking specifically to the patient and family advisors about understanding the foundations of quality projects. So questions, comments, concerns?
Hi, Kelly. This is Pam from the Coordinating Center. I just want to urge everybody, too, to really think about, we're going to be looking for feedback on this presentation. And as you think through what you might need to talk about with your advisors or what materials you might need, we're here to help try and support you with that in co-creating some materials or providing something for you. So please think about that. And if you have questions related to clarifying what kind of materials you might want to put together or what should go in them, this is a great time to ask.
Hi, this is Gaurav Vashishta. Can you hear me?
I'm sorry, say it again.
I had a quick question. Can you hear me okay?
Yes, we absolutely can.
So I guess as we go along on the project, and if we have questions regarding, expectations, participation, logistics, support, who would be the point person?
You can always start with us here at the Coordinating Center. We can involve Kelly as needed if it's a question of having resources or materials, or if there's any sort of guidance documents. We also can involve our advisory committee as well if we're looking at maybe trying to create some materials. But as far as ongoing support or questions about the role of the advisor and that sort of thing, you can always start with the Coordinating Center, and we'll triage from there.
And I guess another question, so do you have material already that kind of simplifies QI?
For the advisor? Is that for the advisor?
Not just the advisor, anybody on the team who's not very in tune with, the steps in performance improvement or process improvement, just something that can help ground the team and, keep the focus, so to speak.
So this next section might have some of that. So this is a kind of a great lead in. What we would like to do from this is take what seems to work to create a toolkit where this could be sort of used as a train the trainer. So when we go through into this next section and I talk a little bit about the basics of QI projects, maybe we can think about also, and if some of you are willing to provide feedback, as to what might need to be an information sheet as opposed to just a slide on a PowerPoint. What might actually work as a handout of some sort in developing a toolkit for people that are starting this process? Does that make sense to maybe think of it that way? We'll see how we can break this PowerPoint into modules of information sheets, because right now we don't have a huge amount, at least not that I'm aware of. Pam, do we have anything already created?
We don't really. I mean, all I have is a little sort of one-page document I sent out explaining what I-MPACT is and what some of the questions some of our advisors might have, but we don't really have a what are the foundations of quality improvement. I do think, having previewed your content, that your next little section of slides here is going to help lay a foundation there, and I think there'll be a good reference or resource in the future. We may need to build on it some more, but I think there'll be an excellent starting point.
Great. Are there any
Perfect.
other questions about this first section or first several sections? Okay, so I am absolutely, staff and faculty, you're so welcome to stay, because it's probably, I think it could be beneficial for you to hear and see what information advisors are also getting. But this next section, and you actually might be able to, add to it as well, because I am not the expert of this next section. I feel very comfortable with this first part and engagement, but when it comes to quality improvement, I'm trying to bring myself up to speed as well. So let's move on into this next group, and hopefully most people will stay on, but I understand if some of you need to go. So advisors, this is particularly for you. So I'm hopeful that you all had the chance to watch this quality improvement video. I'm not going to show it now. I recommend that you watch it. This is a 7.5-ish minute video that is an animated drawing that shows what quality improvement is. And it gave me a wonderful foundation to actually having a better understanding of quality improvement. So these next slides are really going to jump off of some of what you already saw, hopefully, when you watch this YouTube. So quality healthcare by definition, so the AHRQ defines it as doing the right thing at the right time for the right person and having the best possible result. So it goes back basically to that high reliability organization that we all know that there's room for every institution, every healthcare institution, to always do better. And it's always thinking about what is the right thing, let's do it at the right time, let's make sure that it's the right person so that the right result, the highest quality, safest result will actually happen. So I don't know how much of your transition project will actually go into safety, but I tend to gravitate in the direction of safety a lot when I think about quality. Quality and safety are so interrelated in my mind as a parent and as a patient of the system as well, that quality, I want to make sure that first and foremost, that my children are safe when they are in this health, or that I am safe and my husband is safe when we're in the healthcare system. So this talks about improving. So when you think about quality, you think about safety, but you also think about just experiences. So this actually kind of boils down into three areas where we think about personal interactions that we have with people, so that people really start to have an appreciation and some empathy, or not start to, but continue to have that empathy for people that are in such vulnerable, intense, fear-filled, anxious situations. Because when people are having these moments, communication becomes so critical. And so another quick little anecdote to share. So our daughter had brain cancer. my husband and her father is a neurologist, and he was getting information from his colleagues because he works at the University of Michigan. I remember clearly most of the time I was in the fog, and I would look to him in those early days and say, I hope you know what to do, because I don't even know what to do any longer. I had that my emotions had taken over. There was one time I remember, and it was when my emotions, I started getting better control of my emotions. The doctor left the room, and my husband didn't hear something that was a medical piece, that I was the one that was sort of not the expert, but straightening out something that was said. And it really was eye-opening for me, because I put so much pressure on him, because here I was treating him. He's not just dad. He's a neurologist, and he knows so much, and he's an expert, and he could call, and he knows what they're saying, and all of these things that I was pushing really onto him. I realized that those same blocks, those emotional blocks that I had, he had too. He was just as afraid and just as anxious and just as vulnerable as I was. And there were moments where he didn't hear what was going on either. So those are the things that when we think about quality experiences. How can we help staff and faculty understand how and when to disseminate information in these highly charged situations, and how to help, what are expectations, how to set expectations, because usually when there's a bad experience, it has to do with poor communications and inappropriate expectations being set. But it also has to do with making sure that you're not babying me, that I need that space to adjust to this new world, but I also need to adjust to this new world because I'm the one taking my child home. I'm the one that is responsible for her, and I need to manage her health when she's at home, and she's at home more than she's at the hospital. So I have to be involved and participate in all these types of things. So what does that look like? What does participation look like? This also involves processes. We all know that, the discharge processes I shared, wait times, sometimes access to healthcare, registration. These are processes that are fraught with complexity, and how can we make things better? How can we improve the quality of these types of things? Then there are also services, things that also matter. Initially, you think, well, I don't really care much about the parking or much about the food or much about the environment, until you're living in this world a lot, and suddenly not being able to find parking and having another crummy meal, or having an environment that has dust bunnies in it matters greatly. Initially, you don't see it, but at some point you see it, and it's glaring. And so those, thinking about all these different areas are all possible areas where you can have impact. So Pam put together on these next two slides some quality improvement terminology, because there's a lot of acronyms and a lot of words that are going to be tossed around specific to this project, but also more generalizable to quality projects in general. So these next two slides have a lot of different words and acronyms on them that could easily be converted into an information sheet as part of the toolkit. So I'm not sure, Pam, if you had anything you wanted to add about these two slides.
I just wanted to add, too, they're not necessarily specific to quality, but even me coming in from the world of research, I've been in research for 15 years, and so I'm working on my first quality improvement project. I found myself acronomally challenged and learning a lot of new terms and understanding sort of all of the things that sort of drive quality improvement, not just because we want to make the experience better for the patients and the families and their caregivers, which is a huge component. But there are also a number of initiatives and incentives and mandates and that sort of thing that are out there related to insurance and Medicare and Medicaid and what have you that are also behind driving quality improvement. And so there are various measures that I think people may hear when they're sitting in meetings. They may hear about HEDIS, which is a data set, and they may hear about HCAHPS, which is a hospital survey that is conducted. CMS uses it as a tool, and it's not every patient who's discharged will get the survey, but they do survey a sample, and there are measures in there that look at the quality of the patient's experience in addition to the quality of the clinical care and the outcomes and that sort of thing. So I just wanted people to have a little bit of a tool or a reference sheet for when maybe they're sitting in their meetings with their teams, and they may hear some of these things thrown around, and we're going to be talking with our cluster teams about some of the various incentives and how participating in I-MPACT may improve some of the measures associated with those incentives. And so maybe just to give them a little bit of a starting point so they don't feel like they're just scribbling furiously to write all of these various things down and then understand what they are.
Yeah, that's really helpful. And I think that if there's certain terms that might be here or might be specific to any project, that really the advisor needs to have a better understanding. So you, the advisor, you need to absolutely ask for more clarification around this. But you, the staff or faculty, if there are things that you know that's going to be coming up repeatedly, you might want to have a little separate, let's just take these next 10 minutes or 15 minutes to make sure that everyone understands what these words mean and and how this is going to impact the project. But advisors, I cannot stress enough that it is more than okay to ask questions, clarification questions on all of these terms and on all of these acronyms that come up.
And I think it'll be especially relevant, too, because we're asking our hospital and physician organization in clusters to sort of determine what metrics they want to use to measure the efficacy of the interventions they deploy to improve the transition of care. And so there will be certainly a lot of these terms bandied about because these are measures that are pretty standard and universal across many different organizations. So I think they'll probably be exposed to them as they're talking about how do we measure whether what we're doing is working.
Great. Yep. Absolutely. Okay, so comparative effectiveness. I've been learning more and more about comparative effectiveness over this last year or so that I've been working in the research and quality world. And comparative effectiveness boils down to these, and I feel kind of badly, I don't know where I found these 5 questions, and I really do need to cite whoever it was that published this, or maybe not published, but that just said this. But these 5 questions really clarified in my mind as a parent, as a patient, as a person, when I think about if I'm comparing 2 different choices or 3 different choices to each other and trying to figure out what is the best solution, I would need to ask, if I ask myself these 5 questions, and we can ask more than 5, but these are the basic 5, that's really going to help me with my decision making. So when I was giving this talk not long ago, someone spoke up, and it really spoke volumes to me because it's such a, well, for a lot of us, it's an everyday thing, having a teenage driver in your house. And this woman said, I have a 16-year-old daughter, and I look at these questions, and I can say, this will really help me decide whether I'm going to let her use the car. Because if she comes to me and says, I want to use the car tonight, I can say to her, do you really need to use the car? And I can then say, well, talk to myself, well, what are the risks if I let her use the car? And are there other safer options? Can she get a ride from someone else? Can she take the bus? Can I drive her? What is this going to cost if she uses the car? So gas or whatnot. And then insurance, will insurance pay? Who is going to pay for what it is that for her to use this car? So when you think about this, this is impactful in every single area of your life. And when I think about this, this really simplifies, and it takes out the fear that I might have coming into a project saying, comparative effectiveness, I have no idea. I'm not a quality person. I'm not a researcher. I don't know how to compare 2 things, but you do. You do, and you do when you look at these 5 questions and you say, just ask these 5 questions over and over to yourself, and that will help you compare what it is that they're asking you to compare. So when it comes to data, I'll ask anyone to speak up when it comes to data. When I think of data being really just about anything. So data, when you first think of it, you think of data as numbers, but data is so much more than numbers. I look at data all the time when I look at our patient satisfaction surveys, and I look at comments that our patients and families write on the satisfaction surveys, because if I see 1 person, 2 people, 3 people saying, Wow, I couldn't believe that you made me find the car on my own when you discharged me from the hospital. I couldn't believe that no one escorted me to the front door when you discharged me from the hospital. I then stop and say, wow, we just had 3 comments talk about how they were really bothered by the fact that we didn't escort them upon discharge from their patient room to the front door of the hospital. And to me, so you work with data every single day, and video footage can be data. There could be data can be really anything, and it doesn't have to be complicated. Yes, DNA sequences are data, but you're not going to be asked to look at DNA sequences. Looking at everyday things is still looking at data. And so what do we do with the data? Well, I think that most importantly is that we protect data and we keep it private and we analyze it and we use it to make things better for people following in the footsteps. So in the research world, there's a lot of complicating things as far as informed consents and the institution having a review board to make sure that all the research that's being done is making sure that everyone is safe and protected. In the quality world, it absolutely is still important to make sure that we protect the data and we make sure that things stay private. But people are not going to the extent of really delving into great detail with needing to have these formal entities do review process for the most part. We use it to make things better, to make life better, to improve safety, to improve outcomes, to improve experiences, to improve quality. So when we talk about this is something that you're going to be hearing a lot about. I would venture that if the vast majority, if not all, of quality projects follow something called the PDSA cycle. Plan, do, study, and act. Sometimes it's called the PDCA cycle for plan, do, check, and act. And basically this is 4 different phases where you are looking at what you're trying to accomplish, planning that, you are doing something about it, where you're taking action on whatever it is that you're wanting to fix. You're then analyzing and studying it, like we talked about on that other slide, analyzing it, interpreting what this means, and then you're moving forward and you are spreading this and making this work. It might start in one area of they might have a pilot site for a transition in one area with one diagnosis or one unit of the hospital, and then once you go through the plan, do, and study it, and you refine and fine-tune and rewrite and rework and fix, then it can be moved out to something that becomes a formal process because you have made it work. And it has resulted in improvements. So PDSA is something that you'll see over and over and over again. And I'm going to toss this out to Pam again because we really felt that it was necessary to have a generalized understanding of how long making a quality improvement might take. So Pam?
Yeah, so I think, one of the questions Kelly posed to me, and one of the questions I think a lot of even our administrators and clinicians at the clusters, and the patient and caregiver advisors have is, how long does the impact last? How long are we going to do this? How long is the project? And it's important to remember that quality improvement is continuous and iterative. So there's often not a clear end specified when a project starts. Its improvement is never ending, so it's ongoing evaluation of changes to achieve a sustained improvement in a specific area or a specific metric that you want to improve. So interventions are evaluated in the current system. This is one of the essential differences between QI, for instance, and research. Research is a very controlled environment designed to try and reduce outside influences, and quality improvement is looking at making changes in the real world in real time and sort of evaluating whether something that I've just changed today will have some sort of lasting improvement effect over the next week, 2 weeks, 3 months, 3 years. And so many of these projects do not have a specified duration. We anticipate I-MPACT going for as long as we can make I-MPACT useful and helpful to improving the process of care transitions. This first year, most of our clusters have picked one specific target population. So let's say this year, by some miracle, somebody solves every problem in the world associated with care transition issues related to acute myocardial infarction or heart attack. They may decide that they would actually like to look at a different target population, and I-MPACT is designed to allow them to try, to do that. So we don't actually have an answer right now for with specific to I-MPACT as far as how long it'll go. Many of the collaborative quality improvement projects that are funded through Blue Cross and Blue Shield have been in operation for 5, 10, or more years. Our oldest one goes back to 1997, and we have several projects that have been in place since 2005, 2006, 2007. That's a good news story, because what that means is they're trying things and they're continuing to identify ways to keep improving. The project won't continue if for some reason it's not having some kind of impact or if it's not efficacious in some way. So some of the things that would determine how long a CQI project will last, of course, is the funding. Some of it is the efficacy, as I mentioned. Do the changes translate into higher quality care and or cost savings? Some of it is the reach. So is the CQI able to operate in a number of facilities? Do you have a number of hospitals across the state who are interested in participating? Or is it feasible for a number of hospitals to participate? Some of our CQIs have almost every major hospital in the state engaged in their CQI. We're starting small this year. We have 5 actually, because if you count Beaumont, we have Royal Oak and Troy participating. And we hope to add 10 next year. So it'll be a little while before we get to 70 or 77 hospitals, but we do hope to get there. And then the other thing is engagement. So not only, as I mentioned, participating organizations need to have it needs to be feasible for them to participate, but they also have to remain engaged. So when they come on board, they have to continue to do the work at their organization to implement the various changes that are identified, and to continue measuring and continue that feedback loop, that iterative cycle. And so if for some reason that falls off, then you don't have a successful quality improvement process going on any longer. And so it's very difficult to answer the timeline question, but I hopefully have given you a little bit better idea of the sort of things that can affect it.
And the reason why I really wanted Pam to be able to speak to that is because as a layperson, years ago when I entered the hospital system, I was surprised at how long sometimes things took sometimes. And I know that our advisors have actually brought that up also, saying, I can't believe it's taken that long to do X, Y, or Z. And that is the way it is. And so setting that, not just the way it is, it's for those good reasons that Pam shared, but it's setting the expectation up front that this is something that it's not that you come up with an idea and you fix it and 9 months later you're done. It is an ongoing, continuous, iterative process like Pam had shared. And understanding that is, I think, really important so that there's no surprises as you're working through this.
And I think,
so I wanted to
share one more thing.
If I can
just add one more thing, Kelly?
Yes, please.
Okay. I just also want to say, often what appears to be a very simple solution on the surface, even if we were to implement the very simple solution somebody would propose, you'll implement that and it may not have the impact that you're hoping it would have. And so part of the process of QI is to continue digging deeper and finding out what are some of the other things that we need to change to get this outcome that we're looking for. It's often a multi-pronged approach, and it's not usually the process of just doing one specific thing, and we don't usually hit on the right thing right away.
Right. That happens more often. But with hope that having a variety of voices that are part of this, there's some evidence that's showing that something called first-time quality occurs more often whenever you are engaging all of the stakeholders in developing a project, and the other stakeholders would be the patients and the families, which for a number of years have been missing from a lot of these projects. So that's something to also measure, is how much faster did you get to a point where you were actually solving the problem that you wanted to solve by engaging the voices of the patients and families. And it's something to pay attention to and measure. I would be curious as to see how that pans out. So these last several slides are going to be about some specific roles for advisors and some specific projects that we've done at Mott Children's Hospital. So we had an advisory council that was specifically dealing with quality and safety. And some of the things that they looked at was that they were really looking at what are called dashboards. And so dashboards are something that I feel that as someone working in quality, you need to understand what a dashboard is outside of it being something that's in your car. And the dashboard is, in this situation, it is measuring how frequently, how many days has it been since some event occurred. So these are all safety types of things. So bloodstream infections, ventilator-associated pneumonias, unplanned extubations, unplanned readmissions, medication errors, et cetera. And so this is letting people know and then celebrating whenever we're going for longer and longer periods without having some type of error. But it's really important for advisors to understand that a lot of data is put into these dashboards, and these dashboards, in my opinion, many of them should be made in ways that the general public can understand. So these dashboards we actually have posted on our website at the University of Michigan, where you can go. Sometimes it takes a little digging to find them, but you can go and you can see this data on the website that is letting us know what our quality and safety is looking like at our institution. So we actually have advisors also on quality projects taking a look at websites and reviewing the websites and giving feedback as far as this is very confusing, this is too hard to find, you need to rearrange the information on your quality projects. But we also have advisors that have been involved in culture surveys, so that if we're really looking at understanding what the culture is of the hospital, we're getting back to, again, that high reliability organization. Let's take a look at the culture of what patients and families and staff and faculty have going. And we've had our advisors be involved a few times in these culture surveys, taking a look at what is the snapshot of what is going on here today and how have things changed. So there might be culture surveys surrounding transitions, projects and other things that you might end up getting involved with. We have also created public service announcements, for lack of a better way of stating it, on digital screens in our hospital. These clearly came from our patients and families. They talked about what are the most important things that they would like people to know, and here are some of them. And it talks about preventing infection and washing hands, the ABCs of going to successful doctor visit, telling people that they really need to speak up. It is really important that they speak up, and they are part of the process, the decision-making process. And then the medication, understanding medication. So again, here are, depending upon what your project, where it takes you, there are going to be opportunities for you to be able to create education pieces that are educating the people following in your footsteps on these transition processes. Bronson created a video on preventing falls. So I don't have that link here, but that's just another example of something that you can do. And at Mott, we actually had our advisors involved in a quality, it was actually a process improvement. I'm not sure it was officially a quality improvement process, but it was talking about how we can better engage the patient and family during medical rounds, because we were doing medical rounds at the bedside, but we weren't explaining to the patient and the family what their role is when the whole team comes in and they start talking. And when they don't know what their role is, we're not doing justice to this family-centered rounds process. Part of the process is that patient and family provides feedback. So we were able to work with our patients and families and help fine-tune this process to hopefully fix this problem of better informing our patients and families how to participate. We also involved our patients and families in our rapid response team. So for those of you that don't know, a rapid response team is a team that that's available to come to the bedside whenever something just doesn't seem to be right, communication seems to be breaking down, and there's a decline or concern in the patient's status, and the normal communication channels for some reason are just not working. So we have what we created, many hospitals have done this also, is a family-initiated rapid response team, or family-initiated rapid safety team is what we called it with the acronym FIRST. And when we started this at our institution, our staff and faculty, our nurses in particular, expressed concern of, I don't want to share this with our patients and the families because it seems like we must make mistakes a lot if we have to have this team. And the patients and families clearly said, well, my gosh, I don't want to call this team to come to the bedside because I'll alienate my doctor and my nurse, and I don't want to make them mad. And so we really recognized that we needed to find a way to better communicate to our patients and families that you're safe here, but we have this process set up to make sure that you are receiving the highest quality, safest care. So what I'm going to do is I'm going to play this video, and hopefully it'll work, of the compromise of how we what we did to provide this education.
Hi, I'm Mary Lebeski, a registered nurse here in the University of Michigan Health System. By now, your primary nurse has settled you into your room and provided you with the information you'll need to make your stay here a safe one. I'd like to briefly share with you one additional family-initiated program that will make your stay here an even safer one. If at any time you notice that your family member is having trouble breathing or is experiencing sudden numbness, weakness, confusion, or you're just concerned that something's not right, immediately contact your primary nurse. 99% of the time, this is the only step you'll need to take, as your primary nurse will initiate the appropriate measures in response to your family member's sudden health change. If you cannot reach your primary nurse, or if you still have concerns about the approach to the care of your loved one, then pick up the hospital phone and dial 141. It's our version of 911 within the University of Michigan Hospital. After dialing 141, you'll be asked for your name, the patient's name, room number, and to briefly explain the situation. The operator will then page FIRST, the Family-Initiated Rapid Safety Team, a highly specialized medical team who will arrive within minutes to your room. You are in great hands with your primary care staff. We are providing you with the Family-Initiated Rapid Safety Team program in our continuing effort here at the University of Michigan to have the safest hospital system in the country.
So the whole point behind that was to make sure that the language was scripted in a way that made everyone feel comfortable and that we were sending a standard and consistent message for this new quality process that was established. And everyone felt that that hit the mark. But I'm going to go now and reinforce what Pam had just shared, that this is a continuous process, and sometimes we slip and fall back again. So we had this in place for a while, and it was being utilized, and everything seemed to be great. And then we moved into the new Children's Hospital, and the signage went down, and a variety of things changed. And we have to go back and do re-education on that this program exists and to let our patients and families know that it exists. So it really is a project that we thought I silly, in this very silly mind, thought that it was done, we had done it, it's over, but we have to go back and reinforce. So it is never truly completely over, but it changes in how it might look. So one other, just because we're a little short of time, I do want to share this one last video. This is actually, no, I'm not going to, I'm a little afraid we're a little short of time. So no, I take that back. You know what? I'm going to show it. So this was a national campaign that was created by the mother of a young man who passed away due to an infection, a hospital-acquired infection. And so this is something that I think is pretty fantastic as far as how you can get a very powerful message out in multiple minutes, in just a couple of minutes, and then in 30 seconds or so. So I want to show you the medium message, because it's very, very clever, very, very good. And then we'll end this is where we'll end here. So.
My name is Victoria Nahum. I am a patient and the family member of a patient, a valid eyewitness to the recent evolution of American healthcare. I am a safe care advocate dedicated to preventing healthcare-acquired infections wherever they may occur. Our national healthcare system and thousands of hospitals across the U.S. are failing patients who trust them to make them well. They are not effecting measurable change through a consistent commitment to patient safety, caring for patients through highest standards of always use best practices. Thousands of dedicated caregivers are following best practices, but nowhere is it written in stone that others have to. In 2006, our son died from an infection he caught from his medical care. Joshua died for nothing. I do not believe safety can truly and actually exist in America during our lifetime, solely and entirely because of the American healthcare system. Solely and entirely because of the American healthcare system, safety can truly and actually exist in America during our lifetime. I do not believe Joshua died for nothing. Our son died from an infection he caught from his medical care in 2006, but nowhere is it written in stone that others have to. Thousands of dedicated caregivers are following best practices, caring for patients through highest standards of always use best practices, effecting measurable change through a consistent commitment to patient safety. They are not failing patients who trust them to make them well. Our national healthcare system and thousands of hospitals across the U.S. are dedicated to preventing healthcare-acquired infections wherever they may occur. I am a safe care advocate, a valid eyewitness to the recent evolution of American healthcare. I am a patient and the family member of a patient. My name is Victoria Nutt.
So I want to end it on that powerful note that your story, your experiences, your creativity, your wisdom, all of these things are going to help build higher quality, safer care and processes at your institutions, and specifically with I-MPACT in this transition process. And so think out of the box. Make sure that you are carry that passion through, and absolutely you will make a difference. So the last thought I've listed is contact information. So this is how you could reach the coordinating center with Pam and Beth. And if you have specific questions about volunteer advisors and onboarding those that processes, you can email me at this email address. But otherwise, I would send the coordinating center can triage the majority of the questions that you might have. So thank you all. I know we went right to the minute, but thank you all so much for your participation, and I'm really looking forward to see how this goes with I-MPACT.
Thank you.
Thank you so much. Thank you so much, Kelly, for doing this for us. Does anybody have any quick questions before we depart?
I want to thank you personally. I'm a patient experience advisor from St. Joe's, Maryland Markham. This was very well done.
Excellent.
It was very well done, yes.
Great.
Wonderful.
Well,
thank you so much for that feedback.
And
yes, thank you.
This is Geraldine Griffin out of Royal Oak Beaumont Hospital. I was employee and a patient, and this was done very well.
Good.
Great.
Good. Well, absolutely. Contact me if you have any questions, because I look at this, we're building this together, and we're only going to make this, if we make a great product, then everyone will have the opportunity to use it.
Thank you.
All right. Well, thank you all, and enjoy your dinners.
Bye-bye.
Have a great evening,
Bye-bye.
everyone. Thanks for your participation.
Thank
you.
Bye-bye.
Bye-bye.
Bye.
Blah, blah, thing. Damn, I talk right. Tired. Well, I kind of stuttered at the end, but I'm tired. I'm so horrible on the phone. I know. Just today, answers and questions. And,